Yeah, but they're not. Okay, folks, thank you. Sorry to push you to finish, but I want to try and keep us to time. Right. So, group one. I heard some really good stuff when I was listening in. Who's feeding back? Scovia, is it you? You were the last one to. Yep. Away you go then. Let's have some thoughts. I'll let you speak from there because I'm kind and considerate.
Thank you, Darren. All right, I'm representing Group One. Hopefully, I will capture their beautiful experiences well in my explanation. From the group, it came clear that we had mixed experiences in terms of the aspect of sustainability. There were some good experiences that were shared, but there were some also not good experiences that were shared among the team. One of the things that came clear from the different experiences shared is that when it comes to MSF, there is that ambiguity of, are we doing emergency, are we doing long term, are we doing development? Because the example that came out was most times we start with coming for a specific activity that we want to do. Let's say we are doing SV or something like that. And then because of the needs and the demands that come from the community, we start to take in extra services and say, okay, there is a demand for pediatric care, we take it up. There is a demand for this, we take it up. In as much as this is shared with the Ministry of Health and data is presented, but most times the involvement of MOH or kind of like letting MOH take lead on these aspects is not so strong. So this impacts a lot, especially when time comes and MSF is like, you know what, actually we can't do it all and we need to stop this, we need to go back to where we started. And then the question starts, you've raised this expectation in the community, you've opened this door. How do you then answer to them? How do you deal with that? Because that leaves an open gap, and then MOH is not able to cope up with the demands you have raised because we come in with a lot of supplies and everything. And the other thing also that came out from the not so good side is that there is no clarity on the specific objectives of what we are actually doing. What do we want actually? What are our aims specifically for this place and sticking to it? So we end up, spreading out in so many areas. And sometimes the premature closure of projects comes in because of security, because of funding issues, or for whatever reasons. And this kind of leaves the community or the Ministry of Health in a state where they're actually not yet prepared, because as Ministry of Health, they are also struggling with some other aspects that especially the financial, logistical, resource aspects that they cannot cope up with. Something that also came up was in terms of the HR, which is challenging. We'll talk about the good side. It comes in the involvement of the Ministry of Health staff. We do come so much in terms of the incentivization of this Ministry of Health staff, but sometimes we're in a situation where like it's staff who actually don't have contracts with the Ministry of Health, and they are like volunteers because they don't have contract with the Ministry of Health. They also don't have contracts with MSF, and they're just receiving a stipend at the end of the month. And then the question is, what happens to this staff at the end of the day when maybe say tomorrow you leave? What goes on with them? So these are some of the things that came out that we felt, okay, it's not very strong on MSF and sometimes leads to these issues. But on the good side of it, there were some nice experiences that the team shared. One was in terms of the planning and inclusion of the community, or engagement with the community, or engagement with the Ministry of Health. In some projects where we had one of our colleagues share how the community health workers are the ones doing the activity, and these community health workers are not paid by MSF. They are for the ministry, paid by the ministry, and what MSF is doing is just the capacity building of these people, which is helping them to be able to do what is within their means, like bring it down to their means. And so even if tomorrow MSF leaves, they're able to continue because all that MSF was contributing was capacity building for these people. In that, and also in this engagement, there was the feedback that is being done. So like the communities involved, feedback is given to them how things are going and what are the next steps to be done. In terms of the capacity building generally also, we there was an example given of the MSF Academy that has worked well, in that the MSF Academy comes in to train both MSF and MOH, and in this training there is an MOU that is signed between MSF and the Ministry of Health to say that these staff officially don't have this certification to practice this, but we want to train them. A curriculum is shared, they are trained, and at the end of the day, they get certification as a nurse, as whatever profile that they are training. And so tomorrow, even if MSF is not there, these people are able to continue to work officially in that capacity that they have been trained in. And this training has both the classroom, but also the clinical training that really leaves a lasting impression and a lasting experience in the staff. The other good aspect that came up was for some of the projects, right from the start of the project, there is the strategy that is laid down is quite very clear, with risk assessments of what happens if we leave tomorrow. And so this puts the question of what can we do to make sure that the people are able to continue with what we are putting in place. So this is taken into consideration from the implementation, and that's where the involvement of the community and the Ministry of Health comes in. The other aspect also comes in the protocols and protocols that we use in our patient management. So, examples were shared where like protocols were simplified or modified to accommodate what actual MOH has in terms of the medications that are used, in terms of also the registers that are used, so that it's something familiar, it's not just something strange for them at the end of the day. Like it's more or less like it's an MOH facility with MSF supporting, rather than MSF coming with their own ideas, own registers, own medications and all these things. So this is something that's helping them to feel included and appreciative of what is being provided. We also mentioned about the decentralization of services closer to the community. And in this decentralization, what came out strong is the aspect that when it's starting, it's MOH, MSF together, because we're doing the capacity building. And then as time goes, MSF withdraws and lets MOH team take over, because now they are able to do to manage the services or the decentralized sites that have been put in place, and then we just continue from a distance to just support them. And then finally, it was in terms of the resource allocation in some projects where they shared examples of how the discussions are put on table and asked, what can you bring and what can MSF bring, rather than us bring everything ourselves, like to avoid that dependence syndrome that MSF will always provide. So it's like, okay, step up to this point, we will also step up to this point, and then with the time it's kind of like a gradual. Okay, we're at 80%, can we reduce to maybe 50, and then you come to the rest of the percentages. That's I hope I've captured that from the
You've
team.
covered virtually everything there. So where do you start with that? There's an awful lot of incredibly good stuff there. Let me look back at the questions. Sustaining services. Well, you talked about thinking with the Ministry of Health, and it harked back to Amulya's, the conversation after Amulya and Eunice's presentation about the algorithms and the choice of drugs and synchronizing with Ministry of Health. So it would seem that sort of message has got through. So that was nice. The ambiguity, what is the purpose? That surprised me. You said strategy is very clear at the start, and then you start to get what I would term mission creep. You start to do all sorts of other things. Why? Anybody from Group 1, don't leave it entirely for Scovia. Scovia can answer, but I don't want it.
I think in many cases it's because when we get to a place, we find much more needs than we anticipate. And
Oh, come on, MSF's been going for over 50 years.
yes.
Nothing catches you out.
Oh no, we get caught out all the time.
But is that, and that, you should be surprised that you're surprised.
We are surprised that we're surprised. The thing is, maybe because we keep on replacing each other. So I might have the best strategy in place when I'm putting the project in place, but then I'll leave and somebody else will come on and say, but then why aren't we also doing pediatric care or nutrition? Or the needs are there and it's really difficult to
Well,
say
and
no to those needs.
it's really difficult to say no. That's part of the problem.
Yes.
You're MSF, you don't do military, but I want to give you an example of mission creep. The UK Armed Forces deploy, and they used to deploy with orthopedic surgeons and general surgeons and facial surgeons, but they never deployed with an obstetrician or a pediatrician because if you're a female fighter and you're pregnant, you're not deployed, and if you're a child, the British military should have nothing to do with it. However, they deploy a medical unit alongside every military deployment. What does your Mark 1 British squaddy do driving with his Land Rover down the road when he sees an injured child at the side of the road? Pick it up and bring it in. What does your guard on the front door of the compound do when a man turns up with his labouring wife who's in obstructed labour? They bring him in. So the British Army now deploys with paediatricians and with obstetricians. That's mission creep. But they've made a conscious decision that keeping the local community on side is in their best interests. Now, obviously, they don't. That's a variable feast, but they've made that decision. It really feels to an outsider listening to you all talk that MSF goes in to do good, and then the scale and type of good you're required to do gets bigger and bigger and bigger, and there needs to be, forgive me, tighter control. And what I was hoping would come out of this conversation was your decision-making process to take on more. The British Army also has a maxim that says the sickest are treated by the thickest. Historically, your combat technician, medical technicians deploy forward. Your surgeons who can save the life are way back. And so the least trained are dealing with the most critically injured at the time their life can be saved. And they've changed that because they recognise the problems. MSF, to an outsider, seems to have a problem. When it goes in, people do. You're all good people. Oh, very nice, but you're all good people. You want to do right. You can't go past somebody who's struggling or suffering. And so you're doing the right thing. But are you, when you're undermining the local health system, offering things that aren't sustainable, and you get a system such that you can never leave without there being major distress? And you can't have your cake and eat it. So it's something to think about when you're thinking about taking on extra things. What is the command and control process? Is it your squaddy driving down the road, sees an injured child type scenario? Or is it, this is within scope and this is outside scope? The danger there is the moral injury for the staff, because you can help, but you're choosing not to help because it's not inside your mission. But I put it to you, already do that. You pick and choose what you will do and what you won't do. So who's acting as the decision maker? Is it a systematic, organised, structured decision, or is it made by people on the ground? And if you were a leader, what would you prefer? I'm not presenting you with a solution because I suspect were I to deploy, I would be doing exactly what many of you are doing. But somebody needs to be sitting further back and trying to stop. Otherwise, MSF will be the hospitals for the world. One could argue in many places you already are. But why would the local government do it when you're doing it for them? Okay. So interaction with the local government system. I heard in one of the groups you saying they just don't interact. Really? Do they know what you're doing? Is the interaction because they see it as a partnership, or do they just want to know what you're doing so they can keep the money to do something else? Are you backfilling a deficit? I heard a voice. Nope, nobody's speaking up. Okay, thank you. And adopting new activity, well, I've just riffed off that. I emphasise group one, I'm not being critical, I'm just trying to give an objective outside view. And when you're not there, it's easy to say don't. But when you're right there in the heat of the moment, it's really difficult not to do. And I completely get that. Okay. Can I go to group two? Who's the spokesperson for group two? Oh, before I do to group two, any riposte from anybody in group one? Was that fair? Did I throw up some challenges? Make you try think?
I think maybe what we didn't actually have time to come round to is the agreement that we as MSF want to do better and are already seeing situations that, projects that are doing better, that have a strategy or are keeping to the strategy, capacitating staff on the ground who can take over after MSF has left. So I think that's the way that in general we want to go. I don't know, Hikmatullah, if you want to talk about your project.
So my experience is like the question that you asked, who is the policy maker or who is it the people on the ground or it's the people on higher levels in HQs? So from my experience, I think it is supposed to be the person who is on the ground because he has the better picture to present.
She. I take your point though.
Yeah.
The gender non-specified.
Okay, they. Yeah. And but I see in MSF mostly it is the HQ who is taking the decisions. Like once in a year they come to a project and they are not able to cover all the projects. So they come for 1 week. I don't know how do they capture everything in 1 week and then they go with a strategy and it has to be implemented.
And that doesn't work, does it? That's horrible.
Yeah, and that is the problem we have in our project.
But that requires the people on the ground to have the strategic understanding and to stay within mission and control mission creep. What you've just described, I have heard multiple times before, and is the worst sort of leadership. Descend from on high. Have you all come across the ABCD of anesthesia? When we're working in the emergency department, we have the ABCD of anesthesia. It stands for arrive, berate, criticise, depart. They come in, they tell you off, they criticise what you're doing, then they hop off and leave you to sort the problem out. Sorry? Okay. I can see you're desperate to say something at the back. Can we send a microphone to the back? And then I will move to group two.
Yeah, I think I will go a bit opposite from what he just said. I think in the MSF we have a structure of making decisions. We have a good chain of command. Yeah, in the projects we are in contact with the people. We know the needs of the people. It's the project that does the proposal of the project. The planning is basically done by the project. Of course, we are supported by the coordination and the advisors. Then we produce the proposal. Of course, there are things that we cannot know in the project. Sometimes we are over ambitious, and there are no resources to meet everything that we need to do in the field. Then we have a feedback from the HQ telling us this can be done otherwise, or this is possible or not possible. But briefly, decisions are not made solely from the HQ. However, sometimes we have imposed decisions, especially because of emergencies or because of sudden changes in the global trends. Let's say with all the emergencies that are happening across the world, the HQ may need to adjust the strategic vision or orientation in some missions or regions. Then they say, listen guys, in these stable projects we are reducing the resources because we have to respond to emergencies, the new emergencies, emerging emergencies, and we don't have resources. Yeah, thank you.
So just an
I
answer
really
to-
want to
yeah,
move
just
on,
a
but
quick.
go on.
It will be a short. So like as he said that the decisions are supposed to be made at project level. There are a lot of information gathered that is shared, but the final approval comes from HQ. So means we are proposing a lot of things. Whether they accept or not, it's their thing. I mean, it is taken. For what I understand, the decisions are taken there, and
I would accept that the command and control processes are entirely personality dependent. As we heard, there are proper processes, but you're humanitarians. Herding cats. Rules are there as guidance rather than actually to be followed, is a feeling I get listening. You see a need, you deal with the need there and then have to fix it up afterwards to a degree. But yes, there is command and control, but you're trying to control a herd of cats.
yeah, like they take, like I told you that they take a lot of load, and then at the end when they say like we can't control it, you have to have a proper like analyzing prior to taking something, you know. So once you take things and then suddenly you come up with I can't take it anymore, so why did you take at the start, like, you know. So these are the things we really which really makes conflicts.
I didn't start this half an hour conversation that's going to take 40 minutes with the intention of giving you a solution. I wanted to make you feel uncomfortable. And if I've made you feel uncomfortable, then. Okay, group two. Let's have the brief version. Because it looks like it's about to rain. I don't want to get wet.
Okay, so I think most of the points have been told by the group one.
Good start.
I'm really struggling to find points to share, but maybe I would just share an example, like how do we make sure sustainability in our project. So from my last mission in Sudan, from the data analysis that we found that we were serving actually a refugee camp, Tigranian refugee camp, but we realized that most of our patients, like more than 70% of our patients, are coming from the host community. So then what we did, we tried to decentralize our hospital. We collaborated with MOH. We supported some of their hospitals in other locality. So most of the patients actually, they were coming for the treatment of Kala-Azar, because all the MOH facility, they were out of Kala-Azar medications. So then we supported those MOH hospitals with Kala-Azar medications. And we also, as they mentioned, that we also incentivized some staff. And we also built their capacity. We also made sure the supplies are adequate. And also, some of the areas, due to the conflict, we are not able to travel. We had some travel restrictions. But we collaborated with some local NGOs. They had the travel permit to work in those areas. Actually, this is from the Sudanese government, that if we want to work in those areas, we must have collaboration with some local organizations. So then what we did, we collaborated with local organizations, because they had a nice team in the community to deliver messages, to work on the health promotion and community engagements. So we engaged with that local organization and we also trained them, we also built their capacity, we also distributed IEC materials and everything that they need to continue their activities where we are not able to do actively in those areas.
Well, you're talking about surge support and capacity building,
Yep.
which I would feel are completely within your scope. I was particularly taken group one when you talked about community health worker education and capacity building. And you mentioned the MSF Academy. They're really positive developments, and it's how MSF can multiply its impact
Yeah,
rather than it's not just the patient you treat today, it's all the patients that will be treated subsequently. You know,
exactly.
give a man a fish, you feed him for a day. Give him a net, and you feed him for a life. Teach him to fish and give him a net, and
Exactly.
you fed him for a lifetime. Yeah.
Yeah. So the last thing actually we were looking for, that is there any happy ending? I mean, we actually supported MOH, we actually supported the local organization, but when we leave, are they continuing the services that we provided, we supported?
I will pay you later for giving me the ideal link to what we're going to do tomorrow afternoon,
All right.
because I'll pause. Is there anything else you wanted to bring from group 2?
Anna, you want to add anything? Maybe.
So I think one of the points which came forward as a challenge but also as a success was continuity in the relationship building. For example, what Purity told us about her presence here in the Embu project, and other projects where you are like creating a system within an MOH, and like every 3 months you have a different expat, is very challenging.
And that was alluded to by group 1, when
yeah,
staff rotate and rotate in and rotate out.
yeah, yeah,
Organizational memory and the record is really, really important.
yeah, yeah. So I think that the continuity, relationship building, also the different sections complicate the process. We've had some examples of like having different sections in the country creating different expectations with the MOH, while they all are seen as
Surely
MSF.
not. MSF is inconsistent between
Yeah,
its own
they
seats.
were perfect.
Oh.
Were perfect.
Oh, you could knock me
Yeah.
down with a feather.
Yeah. And then another thing which we spoke about is the vulnerable populations, especially as soon as you have, for example, a refugee. So if I look at my own context in my last project in Lebanon, the Syrian refugees, it was very tricky to actually set up a sustainable response or like hand over to a party, especially the MOH.
I need to pay you as well, because guess what we're talking about tomorrow?
Okay, perfect.
You've all got into the story that we're trying to lead here, that today was about pushing you beyond your stable health system and making it wobble. And this afternoon I wanted to show you just what wobbling looks like with mission creep. Tomorrow we're going to look at how do you deal with fully displaced populations. The Syrians are a wonderful example of that. Large numbers of people who are reasonably well educated, if not very well educated. They understand their health needs to a reasonable degree, and they are without their usual logistics chains. They can't go to their local pharmacy. Their normal supply system, their normal testing system doesn't work. So how do we create a system that accommodates that? That's tomorrow morning, sort of. Tomorrow afternoon, we're going to have a conversation about how MSF approaches withdrawing, or scaling back, scaling down, and how that feels. How can you do it? How can it be done better? I don't have a solution, but then neither do you. But we're going to have a conversation about what sort of variables might matter there. And I am going to draw us to a close at afternoon tea. And then I'm going to give you a chance after afternoon tea tomorrow for questions about the assessment and about the module in general, before we decant early to the bar, but you know what I mean. There are people who don't consume, and I don't want to make them feel uncomfortable, but we will decamp back to the hotel and chillax before we come to the conference, which starts on Wednesday morning. There you are. You've survived day 4. Thank you to all those who've taken part today, and thank you for your engagement. You seem to have really got into the groove. I hope you're starting to feel it. You don't need to agree with me. In fact, I'd be quite upset if you did agree with me on everything. But I'm supposed to be challenging you, and I'm good at that. Okay, folks, let's get out and into the bus before the rain starts. Thanking you.